Okay, welcome everybody to the CGHS research webinars. These webinars are put on by the Public Health Department in the College of Graduate Health Studies. Today's speaker is one of our DHA alumni. Dr. Laurie Latvis currently works as the Director of Quality and Provider Education for Blue Cross Blue Shield of Michigan. In this position, she has led a team of nurses and coders who assist and educate Michigan physicians and provider organizations with requirements of the Centers of Medicare and Medicaid Services and the National Committee for Quality Assurance in HEDIS measures, which measure performance in healthcare, and coding and documentation requirements related to risk adjustment. Laurie is leaving Blue Cross Blue Shield Michigan at the end of this week after a 38-year career with many of those years in leadership. Laurie is a registered nurse who received her diploma from the Grace Hospital School of Nursing and her liberal education from Mercy College of Detroit. She completed her Bachelor of Applied Science and Master of Arts degrees from Siena Heights University. She began her career as a registered nurse at hospitals in Southeast Michigan in several patient care capacities. She has been a fellow of the American Institute for Healthcare Quality since 2006 and is also a member of the American College of Healthcare Executives. Laurie has been an adjunct instructor teaching leadership and health care-related courses for over 10 years and will continue to teach following her full-time retirement from the Blues. Laurie currently resides in Troy, Michigan with her husband of 44 years. Laurie has 2 married children and 3 grandchildren. Laurie loves spending time with her family, especially her grandchildren, and watching them grow. Her passion is education and helping others succeed. Laurie's why in life is serving others. And so with that, Laurie, can you unmute yourself and take over?
Sure. Good afternoon, everyone. Thank you for everyone for attending this afternoon. So the topic of my research was what are the leadership competencies expected of senior healthcare leaders to affect positive patient experiences in inpatient acute care hospitals in the United States. And the agenda for today is to talk about the study background and literature review, problem statement and purpose, data collection and analysis, the results and discussion, study limitations, and cover the recommendations of the study. So the study background, my study resulted from the fact that healthcare is a competitive marketplace where part of a healthcare organization's success is based on patients' perceptions of the healthcare experience. Hospital senior leaders must lead organizations by articulating and modeling the goals of their organizations so patients and families experience good outcomes leading to positive patient experiences, satisfied patients, and a hospital's success. The concept of patient experience remains in development, is difficult to measure, although it is known to be affected by senior leadership support of patient experience initiatives in hospitals. Of personal interest is how senior leaders might affect a patient's experience within a large healthcare organization when patient experience involves everyone within the organization and everything that is said and done during the continuum of care. As part of my study, over 150 theoretical and empirical articles were reviewed. Of particular note, patient experience is multidimensional, and improving the experience of care was cited as one of the triple aim in pursuit of improving healthcare in the United States. In addition to improving population health and reducing healthcare costs by the National Institutes of Health. Patient experience has 2 main dimensions, patient satisfaction and quality of care. While studies demonstrate that leaders had different traits than non-leaders, and having these traits gave leaders a considerable advantage over others who lacked them, a seminal study by Hudak, Brooks, Finstone, and Riley in 1993 was identified to be the most important in the field of healthcare administration, and along with several other studies conducted by Hudak, Rook, and Finstone in 1994 and in 98 and 97 by Hudak and others, determined competencies needed for successful executive healthcare leaders. Hudak and colleagues in 2000 shared that all of these studies demonstrated similar competencies required, including professionalism, healthcare knowledge, ethical behavior, communication skills, strategic thinking, and motivational leadership, among others. Athey shared that senior leaders in healthcare navigate a system of unique changes while meeting demands of consumers and payers to improve a patient's experience. Because the healthcare landscape has changed significantly since the implementation of healthcare reform, changing to models of value-based reimbursement, increased technology, and mergers and acquisitions, this requires senior leaders to possess new skill sets. Senior leaders' power and influence of an organization's success can be linked to improving the overall patient experience in a healthcare organization. Determining the characteristics required for today's and future healthcare leaders had been a challenge worth researching. And the study consisted of two constructs, and they were patient experience and senior leadership competencies. So the first construct, which is patient experience, the Barrel Institute, which is highly recognized in patient experience research, defines patient experience as the sum of all interactions shaped by an organization's culture that influence patient perceptions across the continuum of care. And this diagram illustrates the patient experience framework. And the framework includes 5 dimensions, and those are HCAP, patient-centered care, quality improvement, safety, and value-based purchasing. If you're not aware of HCAPS, it stands for Hospital Consumer Assessment of Healthcare Providers and Systems. Construct 2, the Senior Leadership Competencies. It's the second construct, which is about senior leadership competencies. Garman and Johnson define competencies as characteristics of employees with behavioral implications that are thought to be associated with successful performance on the job. So the framework for the second competency consists of 2 dimensions. There are senior leader characteristics and competency models. So the first dimension includes chief patient experience officers, and the second one includes 4 competency models, which surfaced from my literature review. And the patient experience officer's role in healthcare organizations is to address the needs of its consumers from the perspective of the patients, the families, and communities that they serve. Wolf and Prince stated this requires full-time leadership and is a critical strategic role and one that must be part of the senior leadership and have the authority equivalent to their peers, demonstrating the importance of the role and commitment of the organization to its overall strategy. And competency models provide a cornerstone for designing learning programs by specifying performance language to help learners and mentors improve the quality of goal setting, feedback, and identifying high-value learning activities that can accelerate leadership development. And while there are numerous healthcare competency models, the competency model needs to be specific to the organization, its strategic priorities and goals, be role-specific, and recognize behaviors appropriate to the success of future healthcare leaders. So while 4 competency models were reviewed in detail in the study, the healthcare leadership competency model developed by the National Center for Healthcare Leadership, developed based off the work of McClellan, Boyasis, and the Hay Group, was found as more applicable to senior healthcare leadership as it was developed specifically on leadership acumen in healthcare and applicable to healthcare administrators. Therefore, the instrument for this study was adapted from this model to explore what competencies of senior healthcare leaders are needed to affect a positive patient experience in acute care hospitals in the United States. So the problem statement for my study was that positive patient experiences directly affect positive clinical care outcomes and higher hospital reimbursements, although what senior leader competencies are expected to affect a positive patient experience is not well known or has not been proven. The purpose of this qualitative study was to explore the leadership competencies of
We have momentarily lost audio, so stand by. It still shows you as connecting, Laurie. Ooh, didn't like that. Okay. No, can't hear you.
Muted also.
You're muted. Can you unmute yourself and try that?
Can you hear me now?
Yay.
You can hear me now?
Yes, we can.
Okay, how about now? You can hear me? Okay, I joined by computer. Okay, so I believe I was on the purpose of the study. I will go to there. Does that sound like where I was? I will go to the, I'll back up to the purpose of the study. I know I did the problem statement. I apologize for having to backtrack. Was to explore what leadership competencies are expected of senior healthcare leaders to affect positive patient experiences in inpatient acute care hospitals in the United States. And so the final structural model of the study is demonstrated on this page, showing the senior leader competencies associated with the patient experiences with the research question over the proposition. Okay. I'll get back on track here. All right. So the research question was what leadership competencies are expected of senior healthcare leaders to affect a positive patient experience in inpatient acute care hospitals in the United States. And the proposition was that senior leaders exhibit specific competencies to promote a positive patient experience in inpatient acute care hospitals in the United States. So the research design was a qualitative study. A constructivist approach was taken to present the perceptions of the participants, interpret and present the information in a descriptive format. A stakeholder theoretical framework was followed, which offered flexibility for the various leadership responsibilities in the organizations. According to the stakeholder theory, changes in the organization may improve health as behaviors and environmental factors improve. So the instruments and measurements that I utilized, a self-developed research instrument was modeled after the health leadership competency model, which I explained earlier, developed by the National Center for Healthcare Leadership Model version 3.0. The health leadership competency model is an evidence-based and behaviorally focused approach for evaluating leadership skills. The model was developed following extensive research and widespread application within and outside healthcare. And prior to proceeding with development of the survey, NCHL gave their approval for use of their model as a framework for the survey. The survey focused on 28 competencies of 7 domains, which focused on competencies of senior leaders potentially needed to affect positive patient experiences. The study survey instrument consisted of 2 sections following the informed consent. The first section consisted of 8 closed-ended demographic factual questions, and the second section included 8 open-ended questions about specific competencies, and each question provided a definition of the competency and its domain. So each participant was asked whether he or she believed each competency was required to affect a patient's experience. Participants were also provided an opportunity to ask for a copy of the test results once the study was completed. The survey was pre-tested as the instrument was a research-designed, self-administered instrument. It was pre-tested by 3 healthcare leaders familiar with patient experience and competencies to determine if the questions were clear, whether the instruments were clear, the instructions were clear, and whether there were any problems understanding what types of answers were anticipated. IRB approval was obtained. A purposive sampling design was used from purposefully selected U.S. acute care hospitals. And so the population began with 5,600 U.S. hospitals, so that's where it started. Senior leaders, such as a patient experience officer from 402 hospitals, received a request to participate in the survey, and 28 completed surveys were returned through SurveyMonkey. Okay. So primary qualitative data were collected using a survey containing the closed and open-ended questions. Surveys were sent via email through SurveyMonkey to the senior healthcare leader, so it was in the C-suite, or patient experience officer, and they were also located in the C-suite at purposefully selected hospitals. The participation was voluntary, and the qualitative data were collected over a 2-month time frame, with 2 or more surveys returned from leaders in each of the regions except for Region 1. So this slide shows the 9 regions of the AHA and states within each of the regions. So you can note that Region 1 is way up on the eastern side, and that's where I had difficulty getting a return, despite numerous attempts. Data analysis, the qualitative data analysis was conducted using SurveyMonkey and MaxQDA software. Qualitative data gathered from the online surveys was coded, sorted, linked, recoded, and modeled. Some themes emerged and key findings were identified. Here's hospital demographics. So there were participants from the hospitals were from a variety of bed sizes, with more than half, or 57%, from hospitals of over 400 beds. And then 3 of the participants were from for-profit participating hospitals representing regions 6, 7, and 8. So I was really hoping to find one from participating hospital or for-profit, and one from a not-for-profit, but I wasn't able to get one from each. 28 participants returned the completed surveys, and the number of responses, as I mentioned previously, per region varied from 2 to 6. So here's a slide that demonstrates the study participants, and just by chance, 50% were female and 50% were male. Almost half, or 46.4% of the participants, were between 55 and 64 years of age. The majority, almost 61% of the participants, had a master's degree, while 35.7% had a terminal degree or one was in process. About a third of the participants had tenure of 11 years or more within their hospital, and all of the participants were senior executives, patient experience officers, or held a leadership position that was directly involved with leading patient experience initiatives. Thus, the results were included in the study. The results of the qualitative study showed overall that competencies are required of senior leaders to affect positive patient experiences in acute care hospitals in the United States. This was demonstrated by participants who were part of the study at participating hospitals in regions 2 through 9 of the AHA, and provided answers that led to common patterns and themes in response to open-ended survey questions. Study findings affirmed whether the participants believed a specific competency would affect a positive patient's experience. So for construct 1, 4 themes emerged from the study relating to affecting a patient's experience, including the need for communication and collaboration throughout the organization, increasing cultural and organization awareness, a culture of quality, safe, and compassionate care, and respecting patients' values. A few of the participants' verbatims that support the themes that were on the previous slide. Patient experience is rooted in the needs of the patient. Thus, the community collaboration is essential. As a diverse community, needs and desires vary. Cultural awareness is essential. Another participant stated, leadership continually drives each leader to focus on initiatives to reach zero harm for our patients. Leaders work with their staff to improve and track results with dashboards. Our goal to improve healthcare is always at the forefront of all we do. Another verbatim for participant, The domain values explains why we want to improve the patient experience. It is not just to be polite or hit some service excellence standard. It is an essential element of effective care relying on partnership between the patient and their providers. In construct 2, continuing on with discussion, while there were 28 participants and coincidentally 28 competencies in the survey to select from, and in the HLC model, all 28 or 100% of the participants happened to select change leadership, human resources, self-awareness, and self-confidence as being 4 competencies required of senior leadership to affect a patient's experience in acute care hospitals in the United States. A senior leader, in short, who possesses these 4 competencies demonstrates the ability of a leader to make changes and engage others to commit to change, implement staff development, and optimize workforce performance to meet strategic goals of the organization, the ability to know one's own strengths and development needs, and for a leader to have confidence in his or her own decisions, opinions, and capability to successfully accomplish work, especially in challenging circumstances. So some of the verbatims selected by the senior leaders included one of the participants who stated accountability and the ability to clearly articulate expectations for performance is critical for leaders to maintain a patient-centered care environment. As a leader, you must demonstrate through your own actions a commitment to the vision and values of the organization and cultivate a culture of shared ownership for the patient experience. Another participant stated, one must know their own strengths and weaknesses in order to function at your highest level. And yet another said, human resource policies are essential, but must be used in a constructive environment where every worker feels valued for his or her own ideas. And then one participant said self-awareness is a necessary strength in leadership, authenticity, and is important to meet the needs of our patients. So back to the research question of what leadership competencies are expected of senior healthcare leaders to affect a positive patient experience in inpatient acute care hospitals in the United States was answered. And the proposition of senior leaders exhibit specific competencies to promote a positive patient experience in inpatient acute care hospitals in the United States was supported by the study. So the validity of the study, there was triangulation of the data, was completed as each return survey. It was reviewed when received, first of all, via SurveyMonkey, question by question, and then reviewed in different formats by each respondent, and subsequently question by question, including the narratives explaining why the respondent believed competencies affect a patient's experience in acute care hospitals. Qualitative reliability was maintained through an audit trail that was kept throughout the research by documenting the procedures followed and which provided rationale for the method and interpretive judgments made, so others would be able to follow the same process to replicate the same study. Cross-checking codes or intercoder agreement was conducted with one individual who is employed in a corporate survey capacity and one consultant with patient experience and a past Baldrige examiner to determine agreement on the accuracy of transferring the data and the thematic coding with participant anonymity maintained. The managerial implications of the study findings provided a basis for a framework of health leadership competencies expected of senior leaders to address the need to improve a patient's experience. Hospital governing boards and executive leadership may need to be engaged in and supportive of developing senior leadership competencies specific to improving patient experience, and human resource departments needed when hiring and developing leadership development courses. Sorry about that. So the study limitations, Completed surveys covered all regions except for Region 1. The study was limited to acute care hospitals in the United States. The study did not include other healthcare type facilities, for example, ambulatory surgical facilities and primary care facilities. And there was an inability to seek clarification from the participants. So in other words, follow-up from the participants was not sought. So recommendations for practitioners included that the participants in this study confirmed 4 competencies were important to affect a patient's experience in acute care hospitals. It's recommended that additional leadership competencies be added to senior leader job descriptions when hiring senior leaders and responsible for patient experience. In organizational culture, the qualitative study identified the need to involve the entire organization with the need for change leadership as one of the top competencies needed for senior leaders. As executives have many responsibilities, they are also responsible for the health and well-being of the patients that they serve. The patient experience should be included in the hospital's vision, mission, and goals. Improving a patient's experience is a culture change, and healthcare encounters are found at the center of the definition of patient experience itself. And lastly, organizational education and academic curriculum. It is also recommended that education on patient experience is provided by hospitals for all employees and medical schools. Nursing schools and all healthcare related programs include curricula that provides education on the patient experience and how each person in an organization contributes to the patient's experience. Current and future healthcare leaders must be educated that the sum of all the interactions during a patient's stay contributes to a patient experience. And some recommendations for future research include exploring study constructs in other patient care settings, physician offices, ambulatory surgery facilities, outpatient clinics, conducting a qualitative study by collecting data via personal interviews, exploring hospital and senior leaders with and without patient experience initiatives in place, comparing HCAHPS scores of hospitals with and without patient experience initiatives in place, and exploring other dimensions of patient experience. And I've also included a couple pages of references, although they are just a few to share. There are more available upon request. And then I'd like to close now and open for questions if there's any. Thank everybody for joining today, and I apologize for that snafu of losing my voice for a minute.
Laurie, thank you. Were there any surprises to you when you did this? Laurie, can you hear me?
Any questions?
Laurie, I think Dr. Altman has a question.
Can you hear me, Laurie?
Can you hear us, Laurie?
I guess not.
I think she's got the ability to transmit but not receive.
Right.
Marcia?
Yes. Can you hear me?
Marcia, can you hear me?
I can hear you.
You can hear me? Okay.
Yes. Can you hear us? Can you hear us? Oh. Okay, let's try typing our messages in the chat.
Okay, I think I probably can hear you now.
Can you hear me now, Laurie?
I can hear you. Thank you very much.
Okay. So my question was, were there any surprises when you did your research? Any of the findings?
Were there any surprises, did you say?
Yeah. Did anything surprise you? I mean, you looked at the 4 competencies and they're like, yeah, those make sense. You know, change leadership and, you know, Any
You know,
surprises?
yeah, I don't think surprises were there from the competencies. I was disappointed by the lack of participation. I think that was probably my biggest, I would say, disappointment. My other disappointment was that I didn't do a quantitative and qualitative. Um, I chose to do qualitative, and in retrospect, and I know Dr. Fick's looking at me, I'm not even going to look at him, but not even going to look at you. But yeah, I wish I would have done both. My comfort zone is qualitative for a couple reasons, and I wish I would have done both. I know you're laughing at me again. Here we go. No, but in all honesty, I wish, and I would encourage anyone, if anyone's a student on this, I would encourage you to do both. I would not encourage you to do one or the other, but getting experience in quantitative study is really important. And I regret that. I think that I would have gotten a better mix of the competencies had I had more responses. It was just before COVID when the responses ended. It was actually a little bit into COVID, I think. And it was very difficult. And I scoured, right, John? Yeah. Scoured people. I did not let up. I honestly thought I was going to be turned in for harassment. I sent so many emails and begged, and I never thought I would stoop so low. So I was at the bottom of the barrel. I mean, for me, and so I would say, to answer your initial question, I guess, I sort of did, sort of didn't. But I think I would have gotten a better mix of responses and would have, gotten a better flavor. The one thing is that they all came from there was one surprise. The domains, a lot of them fell in the human resource domain, which, yeah, but when you look at the different competencies within there, some of them were not surprises, but when you kind of look at all the rest of them, I kind of felt like there were some others that might have fallen in there. In my area of work, I had patient experience team within my area of work, where I work full time. And so it was interesting, except that my area of work is in physician offices. So it's not with the hospitals. So when you mirror that, it's different in a physician office compared to acute care hospital. So I couldn't even get those, you can't even get context because you don't know hospitals throughout the state. So another message to students is that I was told, and again, I'm not going to look at Dr. Fick, but in the beginning of my schooling, they tell you to network and get to know people. And, you don't know how important that is until you get to the dissertation phase. Now, mind you, I'm a very busy person. So, yeah. And so how do you do that, right? So you search on LinkedIn, you look for different states, you search and search and search. I've never, now I'm getting all kinds of people wanting to know me on LinkedIn. So where were they a year ago, right? So it's really important. And now when I get people asking me for help, I think I just got one of the students, John, 78 people fill out a survey. Where were they at from? Well, they weren't, it was easier, people I work with. So yeah, it was an interesting ride. And now when I look at it, I in retrospect, yeah, I sort of answered your question.
No, it's fine. Thank you for doing it. Appreciate it.
Yeah.
Dr. Latvis, hi, I'm Robert Clegg. I'm the new program chair for the DHA program. I always like to pose this question, despite the limitations that you identified, what's one of the aha moments or maybe one of those sort of key takeaways from your study that you see yourself applying in your new position? I know you're leaving the blues and you're moving on, but what's one of those aha moments that you feel like, I could really use this when I progress into my new career here?
I think it's the leadership piece of it. I think it's the leadership piece of it. I've been a leader for a very long time, and I think I'm going to say it resonates. It resonates, the showing an example, and just continues to resonate with me, is showing an example and being of service to others. That piece of it just still resonates with me, of always helping others. And I don't want to, it is kind of an aha moment, because it continues to come back to me. And when you see that, and I think of it as, I told Dr. Fick, I will never say no to another person again when I get a request for a survey, unless it's Amazon.com, okay, or something like that. But I did tell him, and I want to say that right there, I think, that I take forward with me to always, and it's being of service to other people and helping them, but always, and excelling in your leadership skills. And that's part of leadership. If you understand what I'm saying, that's my thought, is always helping other people. And to me, that is kind of my mantra. Always help. And it really was kind of an aha moment to me that people wouldn't do this. And Dr. Fick was helping me go out and try to get people. It was torture. And I think to myself, how can someone be so busy that that was, I think, really surprising to me. I never thought that would be, and I think you're asking me about the study itself, but to me, it was trying to get those results in. I actually had to extend my, this part of the, course, not because I was, slow at doing anything. I couldn't get the results in. I'm sorry for the noise. I'm trying to hide out from everybody, and sorry. There's a golf course behind me. But anyhow, that to me was, I think, cemented in, right?
Well, and I think there are studies out there right now, especially as times and are changing, that just survey overload. When people are in the workplace, I know, when I was in the hospital, I mean, we were surveyed every day, it seems like. And so I think it's just a lot of people are just sort of overloaded on surveys right now.
Right.
I personally, I answer the Amazon one because I like that $20 gift card that they sometimes offer, but that's just me. I'm kind of addicted to Amazon. But I think that is likely one of the barriers that you're going to find. I mean, in research nowadays, and I had the same thing when I did my doctoral study. I was really trying to get more and more hospitals to be involved in my study, but my topic was somewhat controversial, and there was a lot of fear that the state of California might find out that they responded, this and that. So I was like you. I was almost begging, pleading. I was driving to these hospitals that were 2 hours away to meet with these people to try to get them to participate. So that's one of those evils, I guess you could say, that's prevalent in research. No matter what you do, is participation. But I think just the surveys, that people are just overloaded right now with surveys, and that's unfortunately, that's sort of the sign of the times. But overall, I mean, your study was great.
Yeah, it's a very difficult thing, but I think it would have been a even more interesting study had, had I been able to get more. But it still was interesting to me, and I'm taking a walk. But it still was interesting to me, and it still was worthwhile doing. Although I would have, like I said, preferred to get more, more participants. So, but I think it was.
I'm reading a book chapter. Oh, I'm sorry. I'm writing a book chapter about online research. And I have to tell you, I found that if you would have done a mixed method study, you would have gotten less participants. People would have stopped more in the middle of the study, is the first thing. From a methodological perspective, doing the qualitative data, was important because that's why you have a study. If you would have had this number of people with a survey, it would have probably been a major crisis for you. So your faculty member was quite wise in guiding you in that direction, because you would have maybe had a failed study if you didn't have that qualitative data. And I think this is something we have to be realistic about. And the third thing I would tell you is I think the other thing we're speaking about is the problem with researchers not tailoring their work to target populations that are accessible. And I think we don't spend enough time focusing on accessible populations. What is an accessible population? So you may want to do a study related to the entire country, but the reality of it is you don't have influence in the entire country because you're not Don Berwick, for example. So we have to be realistic about what we're doing with our research. But now here's my question. I was kind of interested in the fact that you did something I see a lot lately in the literature where you placed in your limitations things that are clearly not in the scope of your study. For example, you said a limitation is this is not generalizable to ambulatory surgery centers, for example. But that wasn't within your research question. So I'm kind of wondering why you would put that as a limitation in your study.
So I'm sorry, your question was what?
I noticed that you have a research question that was focused on healthcare systems, hospitals, right?
Right.
And so in your limitation section, you made a comment that the studies, in terms of the generalizability, that one of the limitations is you can't speak to ambulatory surgery, et cetera, et cetera. But I'm curious as to why you placed that in the limitation section when that wasn't the focus of your study.
I'm trying to remember why I did that. I think because I thought that maybe if I had other, if I had done other locations, that it would have added to the study to get other perspectives.
Okay, that makes sense. See.
Yeah, because it's different when you look at patient experience in other settings. It's totally different. It's a different concept. Hospitals are different, and they actually, I did learn that hospitals view patient experience actually as a cost. And I guess that would answer Dr. Clegg's comment earlier that, I guess that was a surprise to me. I don't look at patient experience as a cost. I look at it as more of a given. I mean, it's a given. It's a necessity. And when you have patient experience, it actually reduces, the cost. And I've had people tell me on the side, oh, that costs so much money. Oh, come on. It's going to cost you more if you don't have patient experience. I mean, that's my, I guess that's a bias of mine, but that's how I view that. So, I guess that's kind of a surprise when I see that piece of it.
And that's the shift, Laurie, from the sort of pay for performance sort of mantra to value-based care and the patient experience. So much more, I mean, HCAHPS right now, 60% of the star rating for CMS is patient experience, 60%.
Yeah.
It used to be around 43, but with the shift to that value-based care, they've actually bumped up the percentage to 60%. So, and more and more hospitals are focusing on that. I mean, that's all I did. I mean, my life was HCAHPS for years,
right.
And trying to get people to just be nice and play nice in the sandbox,
yeah,
with their patients. But yeah, you're right. So, but no, again, great job.
Hey,
well, and it's thank
Laurie,
you. And
in terms of your in terms of your comment, you're exactly on the money. I would suggest you take a look at Press Ganey. They've made a contract with the Watson Caring Science Institute because they found in their database that the people affiliated with them were outliers in terms of good customer service scores. So they contacted that institute directly to make a contract because they're curious as to why this caring concept is resonating in the data that they have. So if you look at Press Ganey, you're going to start seeing some more come out about this caring concept in terms of being an important offsetting measure to cost, as you said. So this is a good comment that you made. See.
And in of course my study was on hospitals, so it's a little bit out of my normal workflow. But in an insurance company, we have star ratings, and they just increase the focus on patient experience significantly, as you just said, Dr. Clegg, and it's huge, and it actually knocked the insurance company out of having a 4-star. So it's because of patient experience. So it's not just like when you're saying other settings, it's not just, hospitals, it's everywhere across the spectrum.
I've also learned that patient experience and those scores are very subjective. We'd have patients coming in with one foot on the banana peel, the other in the grave, and we saved their life. They're on the floor, and their lunch was late one day, and we get a survey, and we were just the most horrific place in the world because their lunch was late. And it turns out when I go into the chart, well, we had 4 codes going on that floor during that time.
Yes.
And people were a little busy, but
Right.
just so I there is some objectivity, but there's also a lot of subjectivity to patient surveys and patient experience. But that's something that CMS still looks at, so we need to focus on that experience.
Well, it depends, and it depends on when they get the survey and what happened the day before. Because if you get the survey the day after they got a burnt mail, or someone was angry with them, or they couldn't get an appointment, look out. So yeah, that too. Right, totally agree with you, Dr. Clegg. Yep, totally agree. Yeah, it's a great topic. Thank you, Dr. Fick.
You're welcome. Great job. I want to go back to one of your final slides where you talk about recommendations for future research. I know you're about to retire from your full-time job, and we'll have all kinds of opportunity to delve into future research. So is there anything there that tickles your fancy, so to speak, that you want to, maybe after a month off, jump into from a research perspective?
I need one more day to think, and then you can call me. Just give me one day.
I'll do it. I'll give it to you.
Actually, I told them that they were getting every ounce of blood out of me before I leave, and it is the truth. But yes, I actually am so excited to begin expanding my career in teaching. And in research. I'm not quite sure what, but I kind of there's a few things I like. I like the HCAHPS, comparing it with, the results of hospitals and what I was saying with a program and without. But it's interesting to hear how they think they have a program, but they don't have a program, right? They truly don't have, because just talking with people, they'll say they have a program, but when you dig in, they don't. Now it depends, but yeah.
Okay. I'll give you a call on Saturday.
I know you will. He doesn't he doesn't give up. I was wondering why I haven't heard from you in the last 7 days. I'm sorry? What did you say?
I said that was a great comment that you made. I said that was a great comment that you made about the program, because I would just to say, when you contact John in the couple of days more, I would be focused on the culture. I think the problem is what you just said. There's programs, but nobody's living a culture, and I think that's what Quint, found in his work in Florida. So I think that's the key. I think you're onto the key right there, which is program versus culture, living versus complying. See?
Yes. This is, I will tell I don't know who's on that's a student, but this has been, I think that's what you're referring to, right? That's what you're referring to. Someone at work said to me, "You're doing that? What are you doing?" And I told them, and I said, they don't let you alone. They don't let you alone. You continue on. And I said, and it's great. It's great. It's a great program. And you continue on, and you just provide this over and over. And I think it's a great thing. I don't mean it that way, Dr. Fick. It's great. They support you, not you don't leave when you graduate. They support you continuously, and I think it's wonderful. It's the best program. Best
That's
program.
that's why we always say the ATSU family, because family sticks together even after you've left the confines of our institution. One last thought is you may want to even look at some of the work of David Marks. He's out of Plano, Texas. He's the sort of almost the father of the just culture algorithm. My study when I was doing my dissertation was on just culture, and it's the opposite of punitive culture. When we look at, it's not necessarily an individual, but it's perhaps a systems problem that's occurring. That's why there's okay, was it malicious? Well, then yeah, needs to be some discipline. But is it human error? Is it just a systematic or systemic problem? So take a look at David Marks's work on just culture. I think you'll find it
I'll do that.
useful.
I'll do that. Thank you. Thank you. And I do have to give all the credit to Dr. Fick because he pushes me still today, as I said, and he pushed me for 9 months. So, yeah.
We need to stop complimenting him because first Patrick said he was wise, and now you're, Dr. Fick's head's going to get so big he can't fit out the door. But no, he's amazing. I'm very grateful to have him on the team.
No, it is. It's a great staff at ATSU, and I can't say enough. I only took one course at a time because I was working, and I'm a perfectionist. So that's all I could do at a time. I couldn't get up any earlier than 4 a.m. So, yeah. So anyhow,
Thanks, Laurie.
I do appreciate
Appreciate
it. Yeah,
it.
thank you. Thank you. Any other questions? Okay, thank you. And thank you, Marcia, for the invite. I do appreciate it. And thank you, Dr. Altman. No pressure this time. I told him I still remembered from the last time.
It was very good, wasn't I?
Thank you.
Thank you again, Laurie.
Okay. Yeah, thank you for presenting, Laurie.
Thank you.
Bye, Laurie.
Have a great
Take care.
Have a great day.
Enjoy your
Thank
final
you.
day.
I'll talk
Bye-bye.
to you Saturday.
Oh, maybe.
Bye, take care, everybody.
Bye-bye.
Bye.